Disorders, the focus of this edition of Audio Digest Psychiatry, Volume 18, Number 4, for the week of February 20th, 1989. To begin, Gary J. Tucker looks at the interface between psychiatry and neurology as he deliberates on violent and seizure disorder patients.
First of all, I wanted to make some general premises which are not radical anymore. I think a biologic process underlies every emotional and cognitive state. And I think that it's important to recognize that you could even think of when you get a little sad or you get a little unhappy about something, there's some biochemical change or neurologic change or neurophysiologic change that's causing that emotional change. And when we get into major psychiatric illnesses, there's even more profound biologic changes that are going on. Now, I think there's a consistency to cognitive and emotional states, which is very important. This consistency allows us to recognize them, to empathize with them, and to group them into various disorders. And I think the consistency, if you think about it, is limited to cognitive changes, it's limited to affective changes, it's limited to motor changes, anxiety, if you will, but there are a few limited ways that the central nervous system reacts to stress. And I think it's very important to recognize, especially in terms of differential diagnosis, that the phenomena that we see are very similar. The etiologies can vary widely. So it's important to remember that the central nervous system, I think, has a very limited number of ways of responding to stress. Now, I think it's very important to recognize that explanation does not equal etiology. And just because you can make the case understandable or explain it doesn't mean you have the etiology and doesn't mean you have anything to do with it. The other thing that I think we don't do enough of is we don't practice micropsychiatry. We don't practice looking at subtle deviations from established patterns. And I think we have to really look at minor deviations from established patterns and responses to make us aware of what is going on. Okay, differentiating neurologic conditions or medical conditions from psychiatric conditions. Some of the characteristics that I found helpful in differentiating. The best one, I think, it doesn't fit a diagnostic category clearly. I think when you have a patient and the patient's symptoms and longitudinal course do not fit into any diagnostic category, then I think one should begin to become suspicious. Secondly, if the patient has a good premorbid social history, it should make us very suspicious. If the patient comes in with a good work history, the family's warm and supportive, sociability of the patient's well preserved, then one should think, am I dealing with a typical psychiatric case? Most of our patients, you can see some kinds of premorbid functioning disturbance in their behavior prior to the onset. An abrupt change in personality, mood, or ability to function is extremely important. I think most people, when they deteriorate into psychopathologic conditions, usually deteriorate in some way that you can see the seeds of their previous personality in their present condition. If somebody's been obsessive and they become depressed, they become a lot more obsessive. Abrupt changes are not characteristic. You don't get marked changes in personality in patients who have psychiatric conditions where you can in many of the organic conditions. The other point is rapid fluctuations in mental status. Also, in the same way, motor behavior. A lot of organic conditions, you'll see fluctuations in motor behavior. The European psychiatrists used to call this motor drivenness. It's also got an ego-alien quality to it for the patient. The patient will tell you it's almost like an apathetic response. They don't know why, but they feel they have to get up and they have to move. And the last point that I think is extremely important is the unresponsiveness to usual biologic or psychologic interventions. If you're treating a patient and the patient does not respond in the usual way that you think they should to either your psychotherapeutic interventions or to your pharmacologic interventions, you probably should reevaluate your diagnosis. You may be treating the wrong condition. Now, when we talk about violence, particularly, it really runs a spectrum. A paper by Yudovsky and Silver was really a nice outline of the types of aggression that we see in psychiatric patients and that we deal with. And it ranges all the way from verbal aggressions to physical aggression against objects, aggression against self, and to physical aggression against others. Kind of a hierarchy. When you have a scale that's easy to fill out, the nurses and staff are more likely to fill it out and show there's a lot more aggressive behavior than we're aware of than gets into normal nursing notes. But when we talk about violence and aggression, it really runs a range from verbal aggression all the way down to physical aggression. Now, the best predictor of subsequent behavior, or who's going to be violent, is previous behavior. And probably that still remains one of the single best predictors. The other thing that complicates psychosis and violence in any discussion is alcohol and substance abuse. It's a major precipitating factor and a major factor in dealing with all of these conditions. A very nice study that was done at Rockland State Hospital took 3 groups of patients. These were assaultive patients who did not respond to treatment, responders who responded to treatment, and control psychiatric patients who showed no violence. So these are 2 assaultive groups One responded to a behavioral form of treatment on a special unit, and the other group did not respond. Now, the important thing here, and this carries through with most of the studies that have been done on violence, and that shows the high incidence of neurologic impairment, either soft signs or hard neurologic findings in violent patients. Again, the responders are somewhat less in terms of neurologic findings, and the controls are almost nil. Again, overall family disturbance, very high in the non-responders, less high in the responders, and even less in the controls. And the family disturbance are things like father's psychiatric hospitalization, father's drug abuse, mother's drug abuse, substance abuse, psychiatric conditions are concomitants or correlative factors of violence in psychiatric patients. History of physical abuse, again, very high. Raising the question, is it a biologic reaction or is it a sociologic reaction mixed up together? And I think it's probably mixed up together. Violent suicide attempts are much higher in the group of non-responders. So there does seem to be a group that has neurologic impairments, disturbed family reactions, and family history that is more likely to be violent and violent prone. And that really carries through all of the studies. Intermixed with the question of organicity, or the role of the central nervous system in either psychosis and violence, many of these things can be caused by various disorders of the central nervous system. If you think of drugs, any of the drugs can mimic psychosis or cause violence in psychiatric patients. But we're really talking about two major areas. If you look at the type of symptoms that you can get from frontal lobe disturbances, you'll find that you get exacerbation of pre-existing behavioral traits such as disorderliness, suspiciousness, and argumentativeness, disruptiveness, and then apathy, and ranging down to impulsivity and distractibility. Affective changes, you can get discontrol, apathy, lability of affect, and you can get intellectual changes. So you get social and behavioral changes, marked affective changes, and intellectual changes, particularly with certain types of frontal lobe disorder, particularly impulsive. The evaluation of the patient organically, then, is extremely important. But one must have some kind of indication before going ahead and evaluating the patient. For example, with all the imaging techniques that are available to us, the CAT scan is pretty good. It's good for meningeal lesions, it's good for picking up calcifications, and it's very good for acute bleeds of some kind, subarachnoid bleeds or cortical hemorrhages. It really is not as good as the MRI. Even though the MRI is much more expensive, it's not as good. I've seen about half a dozen cases now that the CAT scan showed nothing and the MRI showed a marked brain tumor. So if you're suspicious of something, if you have either some physical findings or the patient doesn't fit the diagnostic categories, it's important to think about really going all out. Now, Weinberger recently talked about what are the indications for a CAT scan. He talked about cases that show unexpected confusion, dementia, movement disorder, psychosis, which is a questionable one. I don't know if you have trouble with some of your insurance carriers, but we work with a lot of HMOs here that are very cautious about what kinds of diagnostic tests we get, and they wouldn't be very happy with getting a CAT scan for psychosis unless we had something else involved with it. Anorexia, catatonia, late onset affective and personality disorders, and various other types of atypical symptoms. Now, when would you get an EEG? Should you get an EEG on every psychiatric patient that comes in? Probably not. I would be inclined to get an EEG on patients who present with episodic disorders, where the course fluctuates over a period of time, where there's some confusion or delirium, or when they fit some of the criteria that should alert you that possibly you're dealing with an organic condition. The EEG, I think, is underutilized, and people tend to think of the CAT scan before they do anything else. And I think most of the conditions that we deal with, an EEG is often more useful than the CAT scan or the MRI, at least as an initial screening kind of thing. If you have some historical indications or some clinical indications, you should get neuropsychological testing on your patients, and the batteries can vary. Now, what I wanted to spend most time on are seizure disorders as an example of the types of diagnostic problems that we have, and perhaps one of the more perplexing areas in psychiatric differential diagnosis. Now, there are major reasons to look at seizure disorders. One of them is, I think there's a lot of theoretical implications. As far as I know, we have a very consistent illness, such as epilepsy or seizure disorders, that has a high incidence of psychosis associated with it. So as such, it represents, I think, a very interesting theoretical model. It represents something that we can study, an area of the brain that we know has a distinct lesion, and the patient also has associated psychosis. Practically, I think for treatment purposes, it's extremely important. And actually, prior to the development of the EEG, most seizure disorders were classified as mental disorders. Theoretically, it's interesting also in the sense that it's hard to define. I think it's very hard to define schizophrenia, and it's very hard to define seizures. Some of them have a loss of consciousness, some of them have motor phenomena, some of them have sensory phenomena, some have no loss of consciousness. Extremely hard to define. Interestingly, the genetic distribution is almost the same in both conditions. About 10 to 13% of the offspring of schizophrenics will have schizophrenia, and similarly, the same distribution will be true of patients with seizure disorders. Basically, they're both clinical diagnoses. If a patient has schizophrenia, it's basically a clinical diagnosis, and if a patient has a seizure disorder, it's also a clinical diagnosis in the sense that if you see somebody having a seizure, it's probably a better diagnostic procedure than the EEG, and sometimes in a small percentage of the patients, the EEG will remain normal. There are no histopathologic changes clearly that we can find in either case yet, although there are some. The age of onset is very similar, which leads to a lot of problems in differential diagnosis. In males, the age of onset is of some interest in the onset of seizure disorders. Less than 6 months, seizures are usually related to birth injury, congenital phenomena, infections, some metabolic disorder. From 2 to 20 years, it's usually genetic or what you would call idiopathic. Over 20, you begin to get into things that you might call symptomatic, such as from 20 to 35, the most common cause of seizures is trauma, drug abuse, and infection. Over 35 is usually vascular disease and tumor. And in the same way, I think one could think a little bit of psychiatric conditions as being related to those types of conditions. The other thing that I always find interesting is that you really need a rehabilitation team for both conditions. Schizophrenia is very hard for the individual practitioner to treat, and I think you need kind of a team approach. In the same way, patients with seizure disorders need a rehabilitative effort. I saw an astounding figure a while ago that if you have one seizure a year, 60% of those patients are unemployed. So it's got an enormous social morbidity attached to it. Now, there are studies that also point out some more theoretical interest in seizure disorders and in psychosis. One of them was done by Kennard. She did a study where she followed the offspring of schizophrenic parents. And she followed up 3 groups, those from 7 to 12, from 13 to 14 years of age, the offspring, and from 15 to 16. At 7 to 12, 70% of the offspring from schizophrenic parents had abnormal EEGs. At 13 to 14, 56% had abnormal EEGs, and at 15 to 16, 24% had abnormal EEGs. In other words, there seems to be a point in the development of these younger people where the EEG is abnormal, reflecting some kind of perhaps diathesis or predisposition or period of vulnerability, if you will, that changes as the person gets older. So I think it's extremely interesting theoretically to look at these. Now, if we look at seizures, grand mal, petit mal, focal, I think these are familiar to most of you. And the one that's of most interest to us are psychomotor seizures, temporal lobe epilepsy, or complex partial seizures. Now, I use interchangeably temporal lobe epilepsy with complex partial seizures and with psychomotor epilepsy. And we could just look for a minute at what are the diagnostic characteristics of temporal lobe epilepsy, and it's not easy. Basically, we're dealing with a condition that has 3 manifestations primarily. It has specific subjective experiences or feelings, automatisms, and postural changes. Now, in terms of the specific subjective experiences, these can range from forced repetitive thoughts to hallucinations and delusions to depersonalization to anxiety, panic-like attacks, abdominal sensations, but they're fairly specific and they're fairly brief. In the same way, the automatisms are very brief and very fleeting, and they're very typical. They can range anything from lip smacking that looks like almost a tardive dyskinesia type movement to buttoning, unbuttoning clothes, but they're usually very simple, uncomplicated movements. Now, 94% of the automatisms that have been observed are chewing, swallowing, or pursing the lips. Other ones are kind of just looking around in a blank way. About half the patients seem to show that. But basically, they're very brief phenomena. They usually run from 11 seconds to 28 minutes, this phase. It's very brief kinds of things, usually an average of 1 to 3 minutes and rarely over an hour. So we're talking about very brief kinds of phenomena in this case. Postural changes can be anything from just freezing and stopping any activity they're doing to a catatonic-like reaction. Now, this raises the question of, is violence associated with these patients? And there are some interesting studies, one done by Rodin, where they were doing EEG telemetry accompanied by video monitoring. And they had over 1,000 patients doing this, and they found rare instances of violence during psychomotor seizures or during these automatisms. So it's quite unusual to have violence associated with the episode with an automatism. It's extremely unlikely. They're very brief phenomena. The question comes up, could it be kind of a post-ictal manifestation? Could the patient have some post-ictal manifestation, such as an encephalopathy or a status-like episode, and that this is causing the violence? Probably not so. We haven't seen much of this. Most of the patients I've seen in any kind of status, petit mal status, or with status-related complex partial seizures, the patient usually looks confused or is not capable of performing any kind of goal-directed activity. However, there are large studies that say the temporal lobe epileptics have a lot of violence and a lot of seizure disorders. Dorothy Lewis and John Pincus have done a lot of studies showing that patients in juvenile delinquent homes have an extremely high incidence of temporal lobe epilepsy. And it's particularly in the males, if you will. A lot of these patients seem to get shunted, especially if they're lower class, into the criminal justice system rather than into the hospital system. And so they may be picking up a lot there. Basically, I think what we're dealing with in this population is that we have a large group of epileptic patients who there is no violence associated with their behavior, the majority of them. We have a large group of violent people who don't have seizures. There's a small overlap. In that overlap area, there seems to be a higher incidence in some patients with violence who also have seizure disorders. Now, a group of patients had atypical psychosis, which really consists of very episodic courses. They have brief episodes, spells, if you will. They have marked affective symptomatology. They return to a baseline where they have normal functioning, which is very different from schizophrenic patients and from bipolar patients, and they tend to breed true. This group of patients seems to have a psychotic reaction associated with seizure disorders. And it's a very interesting group that one should be looking for when they're diagnosing. Now, when you're looking at temporal lobe epilepsy, there are some things that are helpful in trying to diagnose them. First of all, does the patient describe typical subjective alterations? And the alterations are very simple phenomena. And they're usually extremely simple types of experiences. The same thought over and over again, the same voice. We've had patients that say repeatedly they're turning into women or they're afraid they're going to be homosexual and they just get that thought in their mind and they can't get it out of their mind. And it's just that thought and they get quite panicky over it. It's not the 3D exotic type of hallucination or delusion that we get with some of our borderline patients and some of our more colorful patients. The other thing is, has the patient been observed performing any characteristic automatism? This is very, very helpful. We had a patient on one of our inpatient services, and the inpatient service had a bottle of sour balls, hard candies in cellophane wrappers, and the patient was about to be discharged. She was a young woman who had been admitted to the hospital perhaps a half a dozen times with the diagnosis of chronic schizophrenia. She was standing at the nursing station. The nurse saw her putting her hand in the jar and taking out sour balls, one sour ball at a time, not unwrapping it, putting it in her mouth, and then putting it back. And she did this repetitively, several times. The nurse who had been alerted to these things felt it looked like an automatism to her, mentioned it to the staff when they came in later that morning, and they got an EEG on her, which was the first EEG that they had. She had marked temporal lobe spiking. She was put on anticonvulsants, and a lot of her symptoms cleared. But it was just the observation of the patient performing these characteristic automatisms. And again, they're not the kind of thing where you get somebody going home, writing a note out saying, give me your money or your life, getting a gun, coming back to the bank, and giving the note to the banker, and holding the gun on him and robbing the bank. Those are not automatisms. That is not the kind of thing we're talking about, although a lot of people will try to convince you that is what's happening. These are very, very simple. The patient often looks confused during the episode. The patient often looks like they have some type of alteration in their state of consciousness. They're not quite there, they're not quite with it. Often, almost exclusively, the patient's memory for events is obscured. The patient does not remember what happened during these episodes. Sometimes there's an occasional patient that will remember, but in general, they don't remember. The other thing that I think is extremely interesting, very subtle, and because of the forensic implications of this diagnosis, a lot of patients will try to convince you they have it, is that the patient, after these episodes, usually has some feeling of postictal depression or postictal lethargy. They're tired. They want to rest. If you think of a patient after ECT, in the same way, these patients have had some kind of ictal event, and they either will tell you they feel tired or lethargic, or they will actually want to rest and go to sleep. And lastly, even though there's a large list of symptoms that these patients have, basically they are similar from episode to episode. While the symptoms may differ between patients, for each symptom the symptoms are similar and identical. One of the problems that we get into in diagnosing these patients is that patients with seizure disorders have many psychiatric problems or many behavioral problems that will precipitate seizures that we don't think of very often. The one that's probably the most familiar to all of us and is used to produce seizures on the EEG is hyperventilation. Now, With hyperventilation, you get a marked decrease in cerebral blood flow. You get marked vasoconstriction. There used to be some studies showing that hypnosis and behavior therapy worked in controlling seizures. I think what a lot of these conditions did were they alerted the patient to the fact that they were hyperventilating and gave them a chance or a reason to stop hyperventilating. Sleep is extremely important. You'll get a patient, sometimes it'll come in and the spouse will tell you that they don't know what it is, but their spouse thrashes around in bed a lot at night and they don't understand it. The whole relationship to sleep is extremely interesting, and probably the best diagnostic test if you're suspicious of a seizure disorder is a sleep EEG. If you suspect a seizure disorder, it's often appropriate to get more than one EEG, preferably at times when the person is having episodes. But often the EEG is not abnormal in many of these cases, and you have to get repeat EEGs. Sleep EEG and sleep deprivation is even a better way to diagnose a seizure disorder. It's very interesting. As a provocative test, sleep deprivation can be very useful in trying to elicit abnormal EEGs. But the array of things that can precipitate seizures often get these patients into the hands of psychiatrists before neurologists. Flashing lights, reading, speaking, coughing, touch, pain, sounds, any kind of weird thing like this. I referred a patient once as an antisocial personality, a young woman who had gotten into lots of trouble, and part of the reason that they felt that she needed an evaluation was she was frequently getting into auto accidents. Well, took a history from her, and it turned out the auto accidents, several of them occurred in the same place, the same time of day, when she was driving home from work and driving past a field that had trees very symmetrically planted, and the sunlight coming through the trees was making a strobe effect. And she doesn't remember what happened, but she went off the road at least twice during conditions like that. It was obviously a case of a seizure disorder once we made the right diagnosis. Trauma, hormonal changes, a lot of these are related to menses. A lot of the behavior worsens around the premenstrual period. Fever, emotional stress, and all the drugs we use can relate to these conditions as well. Okay, now in terms of seizure disorders, a lot has been said about interictal changes. Are there interictal personality changes in patients with seizure disorders? And these have been listed in a number of ways as follows: impulsiveness and irritability, emotional lability, hypergraphia, paranoia, nightmares, fluidity of thinking, chronic pain, aggression, religiosity, and philosophical interest. Now, some of these symptoms occur in many patients. They don't occur in all patients. Geschwin and Waxman studied 3 cases and said that the interictal personality of patients with temporal lobe seizure disorders is primarily manifested by hyposexuality, hypographia, and religiosity and philosophical interest. Most of us who have seen a lot of these patients have not found this personality constellation in these patients. Now, the whole question of EEGs in psychiatry is extremely interesting in the sense that we really are not sure what the EEG means. We did a study a long time ago on EEGs on a general hospital psychiatric unit. And what we found was there were some psychiatric symptoms that seemed to occur more with EEG abnormalities. These included thought disturbance, decreased affect, religiosity, persecutory and somatic delusions, auditory hallucinations, impaired personal habits, decreased memory, disorientation, and some perseveration. Now, those are very similar symptoms to the ones we talked about that have been associated with the interictal personality. So there seems to be some behavioral significance to abnormal EEGs. Exactly what, we don't know. About 15 to 17% of the population will have abnormal EEGs. We know that. If you go into a prison population, especially one where there's a lot of murderers, you can get EEG abnormalities that are quite high, usually about 60 to 70%. If you look at juvenile delinquents or patients with MDD, you find much higher incidence of abnormal EEG. So if you take that spectrum from psychiatric patients, people in prisons, the EEG is some reflection, if you will, of the way the brain is organized and has something to do with the way somebody behaves. What that is, I don't think we're quite sure of. But there do seem to be, I think, some value. And I think the computerized EEGs may give us more information on this, but it certainly is some reflection of what is going on. Now, it's very hard in dealing with neurologists because usually their first impulse is that any EEG abnormality is related to the drugs that the patient's on. All the drugs we use, phenothiazines, tricyclics, barbiturates, meprobamate, benzodiazepines, they all cause changes in the EEG. So what you will get most times from neurologists is that they will tell you that the changes that you're seeing are related to the drugs you have on them. In the same way that you send a patient to most internists, they will take them off the drugs that we have them on. I think that there are things that should make you suspicious, though. I think any kind of focal disturbance, as manifested by the EEG, coupled with a symptomatic picture such as we talked about, should make you suspicious, particularly if the patient has some kind of episodic disorder. I think if there is a focal lesion, whether it's paroxysmal or not, focal, but it could be slowing or whatever, and there's an episodic behavioral disturbance and the patient has not responded to other types of medication, it's worth thinking of trying anticonvulsants on that patient. In the same way, I think you should be suspicious of paroxysmal disorders. Any kind of paroxysmal EEG disorder or reading should make you suspicious as well. So I think those two areas are important. Now, how you deal with slowing and things like that is another question. A lot of these relate to some of the medications they're on. A lot of them relate to areas that Hill used to talk about as maturational defects, that they're abnormal, but they're things that shouldn't occur at a patient at this age. They were more normal for somebody at a younger age. In general, though, I think if you think of focal lesions and paroxysmal lesions and the right clinical picture, it should make you suspicious that perhaps the condition you're dealing with is related to that. Now, most of the drugs that have been used to treat seizure disorders you're familiar with. I think the ones that we're using the most are carbamazepine. It's become quite popular in psychiatry. It's also become quite popular in neurology. We tend to use these drugs in higher doses, again, than neurologists. And a lot of the patients that I share with my neurologic colleagues, the family usually ends up preferring to call me because I tend to boost the medication up more and the symptoms stop, and the neurologists tend to refer them back to me just for the symptoms. But most of these we use in quite high doses. For partial seizures, carbamazepine is probably the drug of choice currently. It's supposed to have the most specific effects on kindling of all the drugs. And for any symptoms with psychiatric overlay, carbamazepine seems to have much less in the way of behavioral side effects right now than Dilantin or any of the other drugs, and it's fairly safe and fairly easy to use. Okay, and an article by Udovsky on the psychopharmacologic treatment of aggression I thought was rather useful. When do you use antipsychotics? He would say when the aggression relates to a psychiatric condition, which makes sense if your primary condition is psychiatric, and for the acute management of the patient. Carbamazepine, again, for seizure disorders, and most of the times in using carbamazepine, we use it in a way that we keep increasing the dose until the patient's symptoms improve. Lithium, again, for affective disorders and aggression and irritability related to them. Minor tranquilizers, acute management of violence or agitation, and he's a big proponent of propranolol, which is also seemingly effective for some of these patients.
And that ends Side A, discussions of multiple sclerosis on Side B. This is Side B, Audio Digest Psychiatry, Volume 18, Number 4, continuing a program on neurologic disorders. David R. Mitchell reporting now on psychiatric aspects of multiple sclerosis. First, presenting this brief overview.
MS follows an unpredictable course with a wide variation between patients and within patients. Etiology is not definitely known. The diagnosis is imprecise, relying on evidence of CNS lesions that come and go over time to the exclusion of other causes. It might take years to get a confident diagnosis. There's currently no cure and only partial symptomatic relief. Stresses do accompany the emotional and intellectual changes that are a direct result of MS. This is an impact by the direct CNS effects. I'll describe several emotional syndromes. The first is that feeling of fatigue, which can easily be misunderstood by family, friends, and work associates as laziness or job burnout, low blood iron, or depression. There have been several types of fatigue described, one of them being a nerve fatigue where demyelinated fibers have slowed conduction, and stresses such as a mild temperature increase within the body can bring about a total blockade. There's difficulty for the patient in carrying through plans and commitments, which can lead to relationship problems. Jobs, promotions have been denied because the patient's no longer seen as being responsible. The person may feel like they've got to prove themselves and try harder, which only results to greater fatigue. A second emotional syndrome is emotional lability. This is described as sudden changes in affective expression that may be out of proportion to the stimulus or inappropriate. It's usually of a short duration. As an example, I remember interviewing one hospitalized man who had burst out into tears every time the mention of the word home or family came up in the conversation. This emotional incontinence can be embarrassing to the patient in a social context. A third emotional syndrome is euphoria. This is when the patient has a feeling of well-being that is inappropriate to the situation, and it's a feeling that persists through time. Patients with euphoria seem cheerfully complacent, without concern toward their disability. As a manifestation of MS, it is accompanied by diffuse cerebral involvement and is rare. In a broader sense, euphoria may represent denial of illness, a masked depression, or a response which is felt to be more socially acceptable than a more appropriate sadness. Euphoria can be adaptive within a family system and seen as a sign of psychologic strength. But when the euphoria is so great that the patient fails to recognize their own limitations, strain can be placed on other family members. The fourth emotional syndrome is depression. One study showed that major depression occurs more frequently in patients with MS than in a neurologically impaired control group matched for disability. This report concluded, therefore, that major depression could be a result of CNS lesions. However, this can be questioned based upon unreliability of a retrospective report and confounded by disease variables. Other reports state that depression may be the first clinical symptom of MS. However, since the diagnosis is imprecise and often requires time, depression may respond to onset of some elusive transient symptoms, but actually antedate the diagnosis. Most investigators view depression as a reaction to the illness and the resultant life consequences. Disease states can be a variable in depression, as it's been noticed that as disability increases, depression may become of a longer duration and greater severity. But a common underlying physiological process cannot be ruled out. Cognitive dysfunction is another aspect of direct manifestation of CNS lesions. Half or more of MS patients may show some form of impairment in cognition. Most commonly reported are deficits in abstract conceptualization, immediate and delayed recall, verbal learning ability, and sensory motor function. The dysfunction is not necessarily correlated with a degree of neurologic impairment, nor are they obvious during a cursory interview. Recent research using the MRI has correlated neuropsych testing and MRI imaging, which demonstrates cognitive dysfunction to be predicted by total lesion area and the size of the corpus callosum. What are the implications for treatment for these direct manifestations? First, considering fatigue. It's important to approach the family and the patient about the fatigue to educate that this is not willful. It doesn't represent laziness. Activities may need to be modified so that the peak activity occurs in the morning when the body temperature is lowest, and there are rest periods or naps in the afternoon and before planned activities. Household responsibilities may need to be shifted. Employers may need to be informed about the schedule changes. Emotional lability may respond to a low dose of a tricyclic, such as 75 milligrams of Elavil. Lithium may also be an alternative. In euphoria, this generally doesn't require intervention unless the patient denies their limitations, which could be an aspect of dementia, and require greater structure and supervision. And for depression, the use of a variety of tricyclic antidepressants according to their anticholinergic side effects and the patient's symptomatology. For example, if the patient's experiencing autonomic dysfunction with bladder contractions and incontinence along with depression, then use of a tricyclic with high or moderate anticholinergic side effects would be appropriate, such as amitriptyline and imipramine. If the patient is experiencing greater difficulty with anergy and fatigue, an activating tricyclic like protriptyline would be indicated. And if the patient has an agitated depression and there is presence of spasticity or flexor spasms, then addition of an anti-anxiety agent would be helpful. For the cognitive dysfunction that occurs, a careful neuropsych evaluation is indicated. Cognitive retraining may help in compensating for some of the memory difficulties that are encountered. Psychiatric disorders may coexist with MS, like bipolar illness, schizophrenic symptoms. It's hotly debated as to whether they're caused by the MS, and they should be treated, of course. Also, the treatment of MS involves the use of ACTH, which can precipitate psychiatric symptoms such as euphoria and mania. This can be treated with lithium and prophylactically prevented with lithium. ACTH may also precipitate a psychosis, which can be treated with antipsychotics. There also can be a depressive crash following withdrawal of the ACTH. Next, I'll discuss the stresses that accompany the response to the illness and environmental factors. This is the impact of MS that's determined by the unique nature of the disease itself. Stresses can begin before the diagnosis of multiple sclerosis. The elusive symptoms can be mistakenly identified. For example, patients have been diagnosed as having alcoholism, obesity, psychological problems. They're just overworked. They can also be mistakenly treated, put on stringent diets, admitted to psychiatric treatment centers. Patients may doubt themselves. For example, one woman questioned if she was going crazy or if she was just a hopeless hypochondriac when she presented with transient symptoms. There may be a reluctance of the physician to inform the patient of their diagnosis, as well as just the plain difficulty that exists in early diagnosis, leading to an ambiguous sense of health. The onset of the illness is in the young, usually in the range of 20 to 40, and in the stage of life where people are concerned with marriage, reproduction, career. Common symptoms like spasticity, ataxic gait, intention tremor, visual impairment, neurasthesias, weakness and fatigue interfere with a person's self-image, their productivity, and a vigorous lifestyle. The course of MS is unpredictable. The severity of symptoms can fluctuate tremendously with exacerbations and remissions. Some patients must conduct their lives alternating between health and illness or right on the border of it. Chronic, long-term stress and anxiety can result, and planning for the future is difficult, if not impossible. There's dependence on others that happens in the course. There may be undesired role changes in the family and at work with decreased functioning. Patients grieve their loss of independence. And then there's disruption in family relations. Up to 40% of the patients I've interviewed in the past year and a half have had the experience of family difficulties, divorce, abuse by their spouse, or their spouse perceived as non-supportive or withdrawn. And one woman I interviewed, she described her husband believing that she just was not trying hard enough, that if she really wanted to, she could get better. He would chide her for incontinence, saying, "Now be a good girl and don't wet the bed," and slap her face if she had difficulty swallowing medication. MS may become the scapegoat for all difficulties between partners. Disability can affect the expression of unpleasant feelings. It's difficult to justify getting angry at a sick family member, and thus feelings are kept inside. The patient may fear sharing how they feel, anticipating rejection or abandonment by the one they depend on to care for them. There may be loss of orgasmic sexual functioning. Patients fear that their spouses may seek extramarital relations. Adaptation to a world not geared toward disabilities is also a difficult and stressful task facing MS patients. There are inaccessible buildings for those who are wheelchair-bound, being unable to reach from the wheelchair for money from a bank machine or the phone, relying on taxis for their sole transportation on a limited income. Reported have been a variety of emotional responses such as denial, hysteria, somatic concerns, depression, anxiety. The implications for treatment: first, a careful neuropsychological and psychiatric examination to screen for cognitive problems and resulting psychiatric disorders. I think an interdisciplinary collaboration by neurologists, psychiatrists, and rehabilitation medicine physicians are indicated. The person needs emotional support through support groups, sharing of their experiences, frustrations, and getting information. In some patients, a group may cause anxiety and only reinforce their fears, and it may not be indicated. Individual psychotherapy is also indicated. The core dynamic of the disease for the patient is loss. The patient may need the help to gain feelings of self-worth without productivity that they previously had. Stress management techniques, as patients cannot be insulated from stress, beneficial effects have been noted from the use of stress management groups. Support of the patient's independence. Up to 2/3 may not be classified as severely disabled 35 years after their diagnosis. So, as much as possible, there needs to be the maintenance of activity and a schedule, assistance with accessible housing, transportation, and vocational retraining. Finally, the family therapy. Family needs to be educated about the symptoms. Family counseling to aid adaptation to the illness and future planning, and assistance for couples to find compensatory ways of relating to each other when there's sexual dysfunction.
Concluding this hour, here now is Jill S. Fischer with some recommendations pertaining to sexuality and multiple sclerosis.
Although sexual dysfunction is relatively common in MS, it's received really very little empirical investigation up to this point. The studies that have been done to date are largely surveys of MS patients, and anywhere from half to 90% of the patients surveyed might report some kind of change in their sexual functioning or sexual activity since the onset of MS. In rare cases, there's a positive change, but in most cases, there's an adverse change. Women most often experience changes in their sexual desire and changes in their orgasmic ability, although changes in sensation are also common. For men, the picture is a little different. Men most frequently report changes in their erectile function and changes in their orgasmic ability. To understand the sexual problems of MS patients, or really any chronically ill patients, you have to think in terms of a variety of factors. Now, the studies that have been done to date suggest that there are a variety of neurologic findings and hormonal findings in men with MS who experience sexual dysfunction. And there have been a couple of studies that have reported that the bulbar cavernosus reflex and sacral evoked potentials can be abnormal. Those are probably the most common neurologic findings. Men with MS who are experiencing sexual dysfunction may also have abnormal sweat patterns, which would be indicative of disruptions in the autonomic nervous system. Okay, a second factor that may influence sexual functioning in MS is other MS symptoms. Sexual dysfunction in MS is associated with patients being older, which makes some sense, and having the disease for a longer period of time. It's associated with a progressive disease course, so a more disabling disease course. It seems to be associated with bowel and bladder disturbance and with sensory disturbance, and on occasion, spasticity and fatigue are also reported as being highly correlated, or at least moderately correlated, with sexual dysfunction in MS patients. We have some data on this from the Mellon Center as well, and I've divided it into what women report and what men report because the findings are a little bit different. Both men and women who are experiencing sexual dysfunction report bowel and bladder problems. But for women, the other symptoms differ from those of men. For example, in women, fatigue, pain, diminished hand coordination, and a greater disease duration were the disease characteristics that we found to be most associated with sexual dysfunction. Whereas for men, aside from the bowel and bladder problems, men's symptoms of MS tended to be more in the realm of spasticity or the stiffness, weakness, and balance problems. Sexual dysfunction in MS can also be related to medications a patient is taking. Looking at our sample of patients at the Mellon Center, we find that tricyclic antidepressants are reported as interfering with sexual function by both women and men. And for women, sympathetic nervous system agonists also seem to interfere with sexual function. Now, the sympathetic nervous system agonists, I wouldn't make a real big deal out of because that's based on a small number at this point and would really have to be confirmed in a larger sample. In men, Leorosol, which is a medication frequently prescribed for spasticity, is associated with impaired erectile function. And finally, parasympathetic nervous system agonists such as ditropan, which is frequently prescribed for the bladder disturbance experienced by MS patients, seemed to, at least in our sample, enhance sexual function for men, primarily desire and sensation. And the sense that I make of this is that it may be that if a man has better bladder control, since that's one of the problems that can interfere with a satisfactory sex life, if he has better bladder control, he may pay more attention to his interest in sex, and it may be easier for him to become aroused. In general, what we found is that the effects of medications on women tended to affect the sexual response more globally, different aspects of the sexual response, whereas for men, these correlations seem to be more specific, targeting specific portions of the sexual response. Sexual dysfunction in MS is often related to intrapersonal factors as well. And basically, when the disease arises, people carry around various attitudes about sexual behavior, both sexual behavior in general, what's appropriate, and sexual behavior that's appropriate for chronically ill or disabled people. One thing we find is that there are a number of our patients who believe that sex is only appropriate in the missionary position. And if the MS symptoms interfere with the couple's ability to engage in sex in the way that they always have, some couples choose to forgo sex rather than to be more flexible in coming up with alternate approaches. The individual sense of physical attractiveness is also very important. We found that this was true only for women in our sample and not so much for men. Anxiety over the partner's response is also a critical factor, and again, we tended to find that this anxiety played more of a role in sexual dysfunction for men in our sample than for women. The individual's overall adjustment to the illness or emotional status is critical. Frequently we find, especially early on in the diagnosis, we find that an individual can become overwhelmed and overly focused on the disease and lose interest in a lot of activities, sex among them. Finally, something that is probably not talked about much and may be different than with some of the other chronic illnesses is that changes in cognitive functioning are relatively common in MS. And so a patient may be relatively distractible or may sort of lose the motivation or the ability to initiate activities. And of course, this can extend to all activities, including sex. A final factor is that sexual dysfunction can be a result of disruption in interpersonal relationships. Like the individual with MS, a partner's attitudes are very important as in determining how the couple carries on after the diagnosis of MS and as disability may intervene. And this is true for both men and women. Often partners may curtail sex or withdraw sex from the disabled or affected partner, believing that to ask for sex would put too much of a burden on the individual with MS, and without talking about it, just make the assumption that that would not be appropriate, and so withdraw their affection and their sexual attention. Individuals who may not have had a partner prior to developing MS may find it harder to find a sexual partner, to develop an intimate relationship. And it's very important that individuals have good communication skills to talk about sex comfortably in general and to talk about the kind of accommodations that may be needed to be made. In many cases, there are pre-existing conflicts in a relationship, and those seem to be magnified when a disease like MS is diagnosed. MS can become a convenient excuse for partners not to engage in sex. And finally, and this we find true especially among the more disabled individuals, when the role shifts take place, a healthy partner assumes the role of caregiver, and the more disabled partner has to be care recipient. It's very hard, even for couples who have a basically healthy relationship, to make the shift from that kind of relationship to a sexual relationship. It's important in working with MS patients that you educate them about some of the facts about fertility and pregnancy. For example, the current thinking is that MS has no effect on fertility in women, and rarely can have an effect on male fertility, usually through a sexual problem, a problem in either the emission or ejaculation phase of orgasm. It's also important to tell patients that MS has no effect on pregnancy per se, and there is, to the best of our knowledge, there's no increased incidence of birth complications or birth defects among MS patients. In general, pregnancy does not seem to enhance disease progression, but for about 20 to 40% of women with MS, the postpartum period is associated with a transient worsening of MS symptoms. And it's important for patients to know that as well. Finally, again, to the best of our knowledge, pregnancy and childbearing do not seem to affect the ultimate course of the disease. So basically, the bottom line for patients is that they should not make their decisions about whether to have children based on having the disease itself. That should not be the bottom line. They should go ahead with their plans. Okay, I'd like to tell you a little bit about how we treat sexual problems at the Mellon Center for Multiple Sclerosis Treatment and Research. We take a team approach to multiple sclerosis, and we have a variety of disciplines represented right within the center. Sexual problems are identified in a variety of ways. A patient may come to the neurologist and the nurse at the initial evaluation and may say, you know, I can deal with everything else about the disease, but the most important thing to me is just that I can't get erections the way I used to. Now, I mentioned erections because these patients, in our experience at least, these patients are usually male. My belief is that they're often men who have trouble with other aspects of the disease but choose to focus on their sexual potency as the critical factor. More often, we learn about sexual dysfunction when, at the initial evaluation, the neurologist or the nurse is asking a variety of questions about, have you experienced this, have you experienced that, and often in the context of a discussion of bowel and bladder problems. We'll say, by the way, have you noticed any changes in your sexual functioning, how's your sexual relationship, that sort of thing. Okay, most of our interventions for sexual dysfunction at the Mellon Center are really indirect. Although if we identify a sexual problem, we inform patients about the services of our Center for Sexual Function at the clinic. Most patients prefer to stay within the context of the Mellon Center and to address other problems first. So a lot of sex education and sexual counseling takes place in other settings. And first of all, one of the things, our nurses often sit down with individuals or with an entire family and just give them some basic facts about MS. And it's real easy for them to work in some information about fertility and pregnancy in MS, about sexual problems that may be experienced. And that's often a more comfortable context then for the patient to bring up his or her concerns. Another way we intervene a little more indirectly is that the medical and rehabilitative treatments of MS symptoms may alter the symptoms enough, may improve them enough so that they no longer interfere with sexual activity. And that can sort of free a couple up then to resume or become more active in their sex life. We often take a look at a patient's medications. They may come to us on 10, 12 medications. And we work to simplify their medication regimen, which again can reduce some of the medication side effects that produce some sexual problems. And finally, in the context of individual or couple therapy, some of the intrapersonal and interpersonal issues may be addressed. I also want to give you just an overview of the types of direct interventions that may be suggested for sexual problems presented in our context. Some general suggestions would include just helping individuals and couples explore their attitudes about sex, and particularly sex in the context of a chronic illness. Relative to how it's often hard for couples who are in a caregiver-care recipient relationship to make the shift to a relationship of sexual partners, if at all possible, it's nice to encourage the couple to arrange for personal care to be performed by someone else. Again, that's in the ideal situation. They may not have someone who can. Then you have to help them recognize that it's a difficult shift to make. But if at all possible, that can help them preserve the sexual partner aspect of their relationship. In terms of some specific problems, for example, if an individual, say a woman, is reporting decreased desire, we may suggest that she and her partner purchase some erotic materials or use fantasy to help increase her desire for sex, and which in turn can increase her arousal early on. In terms of erectile dysfunction, we often suggest to patients that they try alternate positions. A lot of times people just haven't thought of that. They don't recognize that if, gee, it's my left side this week, maybe if I prop myself up differently, that we can indeed have sex and make it very enjoyable. Again, for erectile dysfunction, we may suggest erotic materials. We may suggest increasing the stimulation, either electrically or manually. Getting down to secondary problems when the symptoms of MS interfere with sexual activities. Relative to bowel and bladder problems, we may make just some real concrete suggestions, again, that people may not have thought of, just to encourage people to decrease fluids immediately before sex or in the couple hours before sex. A patient may need to be advised to catheterize him or herself before sex so that he or she doesn't have to worry about incontinence during sexual activity. If the person's got an indwelling catheter, he or she may be encouraged to just cap it or tape it. Again, just very practical suggestions, but they can make the difference in a satisfactory sex life for a couple. And a final thing is that we may encourage individuals to plan sex a little more, plan it around a particular bowel regimen, so that if they're having bowel problems, that they can decide to have sex at a time when they know that their bowels are clear.
And that concludes this edition of Audio Digest Psychiatry, published twice each month by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association. This tape is copyright 1989.